Hi, everybody. We're so pleased to have you all here with us. As Edith, who some of you will recognize, just wrote, we have quite a few familiar faces, which is so nice. This really does feel like a community is forming. And so welcome, everyone. We're really pleased to welcome Dr. Neeraj Chaudhary, who will lead this session of our IIH Practitioner Series. Dr. Neeraj Chaudhary is a neurointerventionalist at Michigan Medicine, and he has been such since 2009. He'll tell us more about his story, but he initiated his medical training at the Calcutta Medical College and Hospital, which is in West Bengal, India. And from there, he went on to two postgraduate appointments and a career in the United Kingdom. This included a surgical residency as well as a residency in diagnostic radiology at King's College, followed by fellowships in neurodiagnostic radiology and neurointerventional radiology at London and Great Ormond Street Hospital. From there, Dr. Chaudhary moved to the University of Michigan Health System, in the Department of Radiology and Neurosurgery. He did that in 2009, and there he performs research under NIH grants and cares for patients. Our moderator is Dr. Goban, Dr. Pierre Goban. He's an internationally recognized expert in the field of interventional radiology with more than 30 years of experience in the treatment of vascular diseases of the brain, head and neck, and spine. He's an inventor too. He's a pioneer in endovascular treatment of cerebral aneurysms. He's developed and established minimally invasive surgical approaches to treat acute strokes. Since 2001, Dr. Goban is professor of radiology and neurosurgery and neurology at the Weill Cornell Medical College and director of interventional neuroradiology at New York Presbyterian Hospital, Weill Cornell Medical Center. He's the author of more than 100 articles and reviews pertaining to interventional neuroradiology. So welcome both Dr. Chaudhary and Dr. Goban, and once again, welcome all of you.
Thank you, Barak.
Thank you so much, Barak, for that introduction, and thank you for this opportunity. This is a great way to interact with people who have been sort of delving with the problem of idiopathic intracranial hypertension, and something that the endovenous treatment with stent has sort of come up in the last few years to become established over the last decade. And it's great to be in the midst of Dr. Goban and giants like him in the neurointerventional field, which has largely and very, very effectively benefited from his expertise particularly. So it's great to be able to interact. As Barak was saying, disclosures, I have NIH funding from for R21 and R01 grants. I'm a consultant to Medtronic, and my allegiance still lies with cricket. This is the Lord's cricket ground in London, and I'm learning the ropes with of American football. This is the big house, as it's called in Ann Arbor, about 90,000 crowd capacity. So bustling stadium, as we know. So just as Barak was mentioning, medical school was in 1996 at Calcutta. It's one of the oldest medical colleges in Asia, established in 1848. Just around the same time that medical colleges and schools were coming up in the US, as compared to other universities in the UK, which are like 800 years old. So gives you a perspective. So from there, medical school graduation, and then quite naturally, I felt the urge to pay my respects to the Queen and now the King. So went over to the UK after medical school to learn more. And I was interested more in general surgery at that time. So I did a general surgery residency, and through those years, that was in north of England in Hull and East Yorkshire NHS Trust. And there, through the training, just around the turn of the century, people were doing multidisciplinary meetings with imaging, with other clinical specialties, and then neuro with neurosurgery, neurovascular surgery, and the neuroradiology group. I think there was that interaction which was very, very fruitful to see and crystallized my interest in pursuing neurointervention. It was just coming into its being right around the turn of the century there, as Pierre will also remember. So in the UK, the training, you can only do neurointervention if you are trained in radiology, basically. There is no other pathway. So I joined radiology residency at King's College Hospital. And through that, then did my London Deanery has neurointerventional and neuroradiology training. This is the National Hospital for Neurology and Neurosurgery, which is the only dedicated such hospital in the UK. And it used to be during the wars, it used to be called Center for Nervous Diseases. That's an interesting way of putting it. But so Great Ormond Street is just behind this building, which is the busiest sort of children's hospital there, and also the neurovascular portion of the pediatric work that gets done. So from there, moved to Ann Arbor, Michigan to continue my fellowship for another year as I was waiting for attending positions back in London. But as life goes and takes its turns, ended up as faculty at University of Michigan and have been since 2009. This is our new building coming up in 2025 where we'll be moving into. So progression of different buildings and different structures, but the journey continues. Shout out to my mentors before I get into the talk. Stefan Brew, again, Pierre will know of him or him personally. He is a neurointerventionalist who trained up in Germany and in London and was my faculty mentor. He's back in New Zealand at Auckland City Hospital performing adult and pediatric neurointervention. He's also pioneer and always outside the box thinker, just like Dr. Giametti, who's retired from University of Michigan now. Again, one of my mentors, and Dr. Pandey here is neurosurgery chair, who is dual trained in cerebrovascular and endovascular neurosurgery. And this is our team, just to go a little bit about what we have in our mix. The team has neurointerventional radiology, neurovascular surgery, our neuroanesthesia team, neurosciences, neurointensive care, stroke neurology, and basic science neurovascular research, where most of my work in ICH, intracranial hemorrhage, is via. And this is some of our other teams now in the state of Michigan. We are expanding into western part of the state, UMich West, where our colleagues have joined. North of Michigan, there is Traverse City, Munson Hospital, and we have other hospitals in Sparrow where colleagues have neurosurgery and neurology interventionalists. And then again in my Michigan, which is like a mid-Michigan hospital, where one of our trainees has joined as faculty there. So a good mix of younger and older age group faculty, where our neurointerventional and understanding over the last decade and a couple of decades has improved and diversified into intracranial hypertension, understanding of venous stenoses, and venous stenting. So we'll go into that. I'll outline the talk. We'll talk a little bit about CSF pressures, and it's always a conundrum. Low pressure, high pressure. Low pressure can turn into high pressure, and it's a bit of a cat and mouse type of, in some patients it can become. But we kind of parse it out, and today's talk is mostly for increased intracranial pressure with no other causes for it. So that's why it is idiopathic. We'll look at some symptoms at presentation. We'll look at the role of ophthalmology and how they select patients. We'll look at understanding of venous stenosis, or I like to call it more narrowing in the venous sinus, because I don't know, stenosis has this connotation of arterial wall and thickening and stenosis. From that point of view, venous wall is different from arterial wall. So venous stenosis from that point of view is different in etiology. And then we'll get to the measurement of pressure gradients, and I'd love to see what Pierre's thoughts are regarding that. The patient prep for venous stenting. We'll look at some case examples in the adult and the pediatric population. And then we'll summarize with some outcomes that have been in the most recent review from 2023 in the literature. So we'll go ahead. The clinical presentation, I think, as we all know, it's about 10 times more common in women than in men. The incidence is about 0.5 to 2 per 100,000 in the general population. So not a common disease, but then it is becoming much more common, much more readily picked up now that everybody is clinically attuned to that sort of scenario of idiopathic intracranial hypertension. The presentation is more with headaches and visual changes. Headaches are common, about 75 to 94% of cases. Vision changes are varied. It can be very difficult to ascertain what exactly the vision abnormality is that can be attributed to idiopathic intracranial hypertension, but it can range from double vision to reduced acuity to enlarged blind spots and visual field deficits. So very myriad of kind of like visual symptoms that the patients can present with. Then rarely they can present with fulminant IIH, where there is severe and progressive vision loss over a period of less than 4 weeks. So that is where the antennas go up and more rapid treatment is thought about. And from that point of view, surgical treatments traditionally has been more of a role that it plays in fulminant IIH as opposed to other progressive IIH patients over a period of time. And we'll look into that a little bit more. From a science point of view, papilledema is something that is very robustly present in these patients. And that is a discriminating criteria as well, especially from neuro-ophthalmology when papilledema is detected, patient has other features of IIH, and then conservative management fails, then they get to the point of consulting either neurosurgical expertise or neurointerventional expertise. 95% of patients can present with papilledema. 1 to 2% of IIH have suffered with permanent vision loss. So if this is ignored, you can imagine in the community, mild vision loss, progressively deteriorating people, adequate attention may not be put to that sort of deterioration, and people can lead up to vision loss, but that is rare, which is thankfully rare. Pulsatile tinnitus is another conundrum. This group of patients all tend to have some pulsatile tinnitus, but it is quite common for people to have pulsatile tinnitus, as we have now understood more with the venous narrowing, the turbulence that it creates, and the perception of that by the patient in the form of pulsatile tinnitus. It can be bilateral in 66% of cases. And then the presentation of papilledema shunts is something to think about when patients present with papilledema. Yes, it could be intracranial hypertension, but in non-invasive imaging, I think importance or attention should be paid to the possibility of a dural arteriovenous fistula. So that usually happens at the transverse sigmoid junction in that location and can lead to increased venous pressures without the presence of a narrowing in the lumen of the venous sinus, and that can lead to papilledema. So the presentation can be visual changes, headaches, papilledema, but the underlying lurking cause could be dural arteriovenous fistula. So that's something to keep in mind from the non-invasive imaging. The clinical criteria as it was documented way back in 1985, the Dandy criteria, which was the modified at its outset called modified Dandy criteria, where signs and symptoms of increased ICP were headaches, nausea, vomiting, transient visual disturbances, or papilledema. And then absence of localizing findings in neurological examination, except for false localizing signs, which increased pressure can give you stretching of the sixth nerve and abnormalities related to that. Important thing is the CT and MRI findings are normal. There is no evidence of hydrocephalus or mass lesions. Opening pressures, again, detected first, more than 25 centimeters of water, normal CSF cytological and chemical findings. The criteria that they got modified to further modify Dandy criteria, which was used in the international intracranial hypertension treatment trial, where conservative measures were the treatment arm and the placebo arm was no treatment. And that ironed out to the point that it showed significant benefit by conservative measures. And this was more stricter Dandy criteria that were applied, as we can see here, with more specific attention to MRV and the sinuses being of discrepant lumen. In the prior Dandy criteria, venous stenosis was not something that people were talking about. So this is just a flow chart of management of patients. And you can see headache, visual changes, you get to the Dandy criteria, then you get to the MRI, MRV, non-invasive imaging, no lesions found, ventricles are not dilated, there is no hydrocephalus. And then you get to the point of headache, but no papilledema and with papilledema. Then that goes to lumbar puncture is obviated if there is papilledema, and then get to the conservative management. If the papilledema is not there and the suspicion is high, then lumbar punctures are done, and then people look at the opening pressures to get to the diagnosis. Nonetheless, conservative management is the first port of call. And here, in this schematic, etiology-wise, why it's that chicken and egg thing that all of us grapple with. Does the venous narrowing happen first and then lead to increased intracranial pressure? Or is there an abnormality in the increased production of CCF? So choroid plexus, as we know, is the source where CSF is sort of secreted into the ventricles, and also from the ependymal cells as the fluid gets into the ventricle and circulates. Absorption-wise, there are these arachnoid granulations, as we all know, the subarachnoid membrane outpouches into the venous sinus, and then the pressure gradient takes the flow of CSF into the vein. And that pressure gradient is what is altered when there is either luminal narrowing, secondarily from increased pressure, or secondarily from the narrowing itself creating a gradient, increasing the pressure, which obstructs the absorption of the CSF and damps up the CSF to causing intracranial hypertension. Lately, more perivascular space efflux and glymphatics have been incorporated into the etiology. And that is a little more intricate, and people are understanding that level of perivascular space and lymphatic channels, which could play a role in this pathology. And as we said, the diagnosis is by diagnosis of exclusion. You're making sure that no other causes are there, which can lead to intracranial hypertension, and then you get to the diagnosis. So conservative management, typically with Diamox and Topiramate, which are basically fluid reducing, CSF fluid volume reducing agents. And that, as I was saying, that has got class 1B evidence to improving visual fields, quality of life, papilledema grade reduction, and then decreased CSF pressures compared to placebo. So that is where the evidence lies. And then over the last decade, more interest in, as technology has improved and venous access has improved, attention has shifted to the venous stenting side of things. But initially, surgical intervention was what was used, and that is optic nerve sheath fenestration, which is depicted here, where the eyeball is kind of like fixed with medial rectus being fixed with some sutures, resection of the medial rectus, turning of the eyeball, and then getting to fenestrating the optic sheath here, as depicted in the schematic. That has success rates which are has complication rates as well, and people started to study that in a trial form, but that trial did not get to fruition because of poor patient recruitment. And as I was saying, back in from the early 2000s, this understanding of venous flow in the large sinuses, and over a period of time, development of, people talk about these extrinsic or intrinsic stenoses. Intrinsic is wall narrowing. Extrinsic is because of the increased pressure, diffuse narrowing in the sinus, which negatively affects the cycle of CSF absorption. So that has brought attention to venous stent or venous dilatation that can be done with, people tried it with balloon angioplasty, and Pierre again would love to see what his thoughts are about balloon angioplasty of the venous sinuses. It did not lead to sustained benefit. So people then went to the stent placement, which has been effective for the last, I think, decade or more. Growing evidence is there that that procedure helps. This is just a outline from the publication cataloging all the different case series and retrospective series that are out there documented. And as we see here, stent application has sort of increased over the years, 50 patients, 60 stents. This was in 2011. And then further larger trials are coming, larger studies are coming through 2017, 41 patients. And we can see more incidence of disease in the female, mean age, younger age group, BMI, as we know, body habitus effects. And then we have the pressures, opening pressures, pre-stent and post-stent pressures, which we can see favorable change of pressures or pressure gradient normalization. And as we see, the improvement in symptoms is pretty dramatic. And all the parameters that are there that people were measuring with the conservative arm of the trial also get favorably affected by the stent placement. Complications are low, but they're there. And that is what sort of draws pause to our how aggressive one can be in doing these procedures. This is angiographic follow-up of the same sort of cohort of trials that are listed here. Varying degree of follow-up. Again, we see the degree of follow-up has increased over the years, and people have become more robust in following the patients that are stented. And we have some restenting patients, but low incidence of restenting. And restenting criteria in people who are starting to do these procedures will probably not see this. If you have been treating this for a reasonable period of time, then you will see that patients do develop recurrent symptoms. They do develop narrowings at other points in the venous sinus, which would need restenting. So going back to patient selection, it is very important to have neuro-ophthalmology colleagues in the team. They review patients, they get the presentation of these patients presenting to them with papilledema, headaches, and visual disturbance. They undergo the conservative management when it fails with increasing dose over a period of about at least a month of increasing dose that other help is sought. And imaging is very important, MRI, MRV, CT venogram, where detection of the venous luminal irregularity is sort of first seen. With failed conservative management and luminal narrowing on non-invasive studies, then the patients come to diagnostic angiography and venography. So we tend to get those patients at that point in time where we do an arterial angiogram and a venogram with pressure measurements to identify if there is a gradient that is positive, to select those patients as a target for stent placement. And then the selection of side, if there are bilateral gradients which are increased, how do you select side? Again, it's up in the air, but symptomatically, the dominant sinus, things that we think are probably a little increased gradient on a particular side, we tend to do unilateral stenting. We don't tend to do bilateral stenting in the same sitting. But again, we'll love to see what Pierre's thoughts are on that. And dual antiplatelet therapy is kind of like mandatory with any endovenous or endoluminal stent placement that needs to be up and running with assays. We always do assays to assure that they are therapeutic before we get to the stent placement procedure. And as we all know, there are no dedicated stents yet. There is a River Stent, which is there. I think the trial is complete, and then patients are being followed up currently. So we'll see what that trial results show. But at the moment, the stents are basically off-label use that we place carotid stents into venous sinuses. This is going into some case examples. 44-year-old female referred to neurointervention from ophthalmology for IIH, pertinent history of BMI, 44, multi-years of headache, recent visual decline in the last 6 months, trialed on Diamox. We can see that clinical picture, that same story getting through. Vision continued to deteriorate. Patient cannot tolerate higher doses of Diamox, and then comes to opening pressures of 34, improved to 21 with drainage of some CSF, but that cycle did not sustain. So visual acuity is still deranged. And here, more of ophthalmology and neuro-ophthalmology colleagues will be able to interpret this better than me. But deranged RNFL layer, which is retinal nerve fiber layer, which is a little higher than the baseline. So a good case for us to interrogate further with catheter angiography and venography. So here is non-invasive imaging, as I was talking about. So this is MR venogram. Contrast enhanced venography is what is used. And as we can see here, there is diffuse narrowing. But then if you look at the right-sided, hopefully it'll stop. It doesn't stop. The site of the stenosis is right around in this area at the sigmoid, transverse sigmoid junction. And there, this is contrast enhanced, post contrast enhanced T1 weighted images, where again, we see the sinuses, but not as distinctly as the other modality. But on the right side, we can see the luminal narrowing that I was talking about. There is a prominent arachnoid granulation there also. And then we get to the catheter angiogram. So arterial angiography to look at venous sinuses, that is also a thing that needs fine tuning. When do you do the venogram? You give arterial injection of contrast. If you image, you will see the arterial side of things. You want to see the venous side of things with arterial injections. So that diagnostic value is basically trying to image in a later phase of the arterial injection. So you can see the sinuses better. This is 3D rotational angiogram with an arterial injection, and shows on the right side again this narrowing that is there where the vein of Labbé is coming in, and that's that transverse sigmoid junction narrowing on the right side. So possible area to interrogate for pressure gradient measurement. So with venography, we put a microcatheter up in the superior sagittal sinus, and then we inject contrast on the vein side. So we do a 3D rotational angiogram or a 3D rotational venogram to delineate these sinuses better. And as you can see on the right side again, there is narrowing at the transverse sigmoid junction, which we interrogated with further pressure measurement. So we do pressure measurements. Again, would love to hear how Pierre does pressure measurement. It'll be an interesting thing to know from him. But we do prograde catheter placement in the superior sagittal sinus, and we do one on each side. We have a guide catheter up in the jugular vein with at least a 6 French MPC or a luminal guide catheter, which has a larger lumen than the microcatheter, so that we can get good pressure measurements or realistic pressure measurement from the tip of the guide catheter. So we do 2 pressure measurements at each point. This pressure measurement from the guide catheter is constant. And then we have the microcatheter, which we move from the superior sagittal sinus to the torcula, the distal transverse, mid transverse, proximal transverse, and then distal sigmoid, mid sigmoid, proximal sigmoid, and then the catheter gets flush with the guide catheter to have equal pressures documented. So we do this on each side. And in this particular case, as you can see, the pressures from the superior sagittal sinus increase to about 30 millimeter of mercury. And that dropped down to about 13 across the area of narrowing that we were detecting before. And that became the target for us to stent. So the patient then comes back with loading of antiplatelets, assays, therapeutic, and then undergoes the stent procedure. So you can see that this is the area of narrowing here that gets the stent placement. This is microcatheter within the superior sagittal sinus through the stent, and then doing a venogram to assess luminal caliber. And then we do pressure measurements again through the same protocol as we had done prior at the time of interrogation. And that gradient in this case, particularly as we see, normalized from 17 to a 4 millimeter of mercury. And this is a rotational venogram with the stent, which we do as well. It gives us a good Dyna-CT type image, which we can extrapolate from these images to, I'll show you an example of that Dyna-CT type image that we do get. And you can see how the luminal narrowing has been restored with this stent placement. This is a Cordis stent that was placed in this patient. Another case example, this one, the patient presented more with prominent pulsatile tinnitus than the visual symptoms. There was decrease in visual acuity, but pulsatile tinnitus was more prominent. Patient referred to us for, again, our neuro-ophthalmology colleagues, conservative management that had not given benefit. Vision was still worsening over time, and that became, again, a target for us to interrogate further. This is, again, MR venogram, contrast enhanced, again, showing some right-sided narrowing here, maybe narrowing here on the left side as well. So it's the typical type of case where there is bilateral, maybe, area of narrowing here in the luminal caliber. This is post-contrast T1, which gives us, again, another look at the venous sinuses. As we can see here, the jugular bulb, and then this area of narrowing bilaterally. So we went ahead to do the same arteriography here, 3D rotational arteriogram looking at the veins. And we can see that the narrowing here is present on both sides, little more prominent on the left side here than the right, but nonetheless on both sides. And again, we show this on this 3D rotational venogram. We can see this narrowing as we go through on the right side and the left side. So we do pressure measurements, as we talked about. And this was equivocal. The pressure measurements were more, was kind of like 10 millimeters of mercury. We tend to use 8 millimeters as a threshold. Anything above is considered significant from our point of view. And I know there has been literature also that now suggests that even lower pressures are significant and could be target for treatment. But because this patient had right-sided pulsatile tinnitus, we opted to treat the right side first. So we went ahead to treat the right side, and here patient's right transverse sigmoid junction narrowing opened up with the Cordis stent, and 8 by 40 millimeter stent is what we used. I feel measurement, again, sizing is still an issue, appropriate sizing. I would love to have like smaller stents, but not as big of a radial force as these stents have. That is probably the reason why the patients develop end of the stent or edge of stent narrowing with period of time. This gradient here, as we were saying, reduced post-stent placement from 10 millimeter to 6. So effective again, and this patient was followed up 6 months following the stent procedure. This is arteriogram at 6 months showing the opening, the stent patency and opening up of the narrowing, and her pulsatile tinnitus dramatically had improved. We'll see, we're still in follow-up of this patient whether the pulsatile tinnitus comes back, because the gradient was also there on the other side. So we'll now move to our index case of pediatric IIH that we have done in the last couple of months. So 12-year-old female diagnosed at the age of 10 with IIH in the setting of headache and papilledema. Only pertinent health history of elevated BMI was of 28. She'd been trialed on Diamox for 2 years, progressively worsening headaches, decreased visual acuity, and RNFL again abnormally affected, as seen on OCT. Opening pressures were 32, some improvement in symptoms with drainage of CSF, but again, good case for us to interrogate further. And non-invasive imaging, again, MR venogram. Here it shows diffuse area. This is one of those where there is extrinsic, people call extrinsic area of narrowing. It's diffuse segment in the transverse sinus, which showed a reasonable length of narrowing in this patient. So we went ahead further with pressure measurements, as we talked about. Again, arterial angiogram looking at the venous sinuses. And as we can see here, this area of narrowing that we see on the left side with a diffuse segment of luminal caliber change. And this is, again, catheter in the superior sagittal sinus with 3D rotational angiogram or venogram, depicting that area of narrowing on that left side in the transverse sigmoid junction. pressure measurements in this patient. On the left, slightly more than the right side. So we took that as a target for treatment than the right side. And we know the target here is this diffuse area of narrowing in that distal transverse and proximal sigmoid junction. And again, we placed the stent, Cordis 7 millimeter stent. Um, in this patient, it was tortuous, like as in our femoral vein puncture did not allow us to cross this area of narrowing. So we had to change to a jugular puncture here. So we went to the base of neck, jugular puncture. And again, something I would love to see what Pierre's experience is in terms of access. But we tend to do femoral first. If that doesn't allow us to get around the area of narrowing distal with the larger intermediate catheter, which allows the stent to, these are the stiffer stents, to go across. They usually get hung up at this point where we are trying to introduce these stiff stents. The catheters start to come back, and then access becomes a problem. So we tend to make sure that we cross the stenosis with an intermediate catheter, then be able to load the stent through that, remove the catheter, and then deploy the stent. So that is typically how we do it. And jugular venous puncture is resorted to when femoral venous puncture is not allowing us that access. 8 French or 7 French long sheath we use in the femoral side. Guide catheters, we use a bunch of them. We have now gravitated to using this 081, which is more, which is kind of like allows through a 7 French long sheath. Cerebrace from J&J is something that we have used. BMX 096 is again penumbra guide catheter. Neuron Max, as we have now sort of gone on and with stroke thrombectomies, that is bread and butter, guide catheter. Then we have the intermediate catheter, stiff glide wires, Terumo glide wires, the glide advantage wire, which is something that we use often, which allows us that robust sort of tower of power, as you may call it, to allow that catheter to go across those tortuous bends and go across the narrowed segments. Prograde catheter we use a lot for pressure measurements. We tried to use the BMW wires where the tortuosity is not as significant. That itself allows us to go across. But we have tried to use not the exchange length, normal length BMW, about 190, 200 length wires, because the stents that we use are monorail and they don't need long wire lengths. But if we use prograde catheters, we get into this situation that we have to exchange with a longer wire so that the stent can be delivered, which defeats that purpose of using the shorter length BMW wire. And as I said, jugular puncture at the base of the neck is something that we resort to when it's difficult. This construct is not allowing us to access beyond the area of narrowing. And again, no FDA approved stents at the moment for this particular indication. Carotid stents are used. This is the different types of carotid stents that we use: single layer, open cell design, Zilver stent or precise stent. These are all stiff stents. Zilver is a little bit softer than the precise, but wall stent and precise stents are stiffer. Casper is not available in the US. It's a dual layered stent, closed cell design, easier to navigate. This is again from Serenity. The River Stent is something that we want to hear about and see what the trial results will show. So these are basically the River Stent is designed with variable caliber and longer lengths. So it can attack sort of a diffuse narrowed segment better, where we don't have to telescope stents and have more than one stent put in. So going more towards, this is another example from our Dyna-CT type image. You can see the stent positioned in the venous sinus in this transverse sigmoid junction. This is that MIP image constructed from the venograms, MR venograms, which is showing this area of narrowing and which is opened up quite effectively with these stents. And quite consistently, the gradients fall off as soon as you place the stent. And we know that that is effective. So looking at outcomes now, this is a publication from 2023, which is a nice summary article, a state-of-the-art review that gets published every so often in Journal of Neuro-Ophthalmology, and is a nice article from, again, colleague, Pierre's colleague, Dr. Patsalides, who is an author on this. So they reviewed 49 studies, 45 retrospective, 4 prospective studies. How we're doing for time? Reasonable, okay. 18 case reports, 3 cases or less, total of about 1,600 patients. So a good number of patients that were collected. 250 patients of this group that had reported pre-post stent opening pressures had a drop, significant drop from 30 centimeters of water to 19.7. 79% of those with transient visual obscuration in the 201 patients had resolution. So we see the problem with these retrospective combined analyses. The patient cohort drops from this total number significantly. Percentages do carry meaning, but the meaning, again, becomes less important if the N drops. Pulsatile tinnitus resolved in 84% of patients, again, 500 patients of that group. Diplopia, 93% in the 86% patients that were documented. Blurred vision improved in 76% of patients, again, in this group of patients that were studied. Headaches resolved. Headache is a conundrum. Headache, when we counsel patients, we don't say that we are doing the procedure for relief of headaches. Headaches are kind of like a toss-up. I think there are people who believe that headaches can be favorably affected. And just to give you some anecdote, Nick Higgins, one of the pioneers in 2001, 2002, who had done the first few publications with venous stenting, and he's always been an ardent sort of advocate of venous stenting in this scenario. His initial thought was headaches get better, papilledema gets better. The goal of treatment is treatment of headache as well. But his thought has also evolved over the last sort of decade or so. And Nick also now says that headache is not the goal. It may or may not improve, but papilledema is a definite goal, an objective marker that improves after venous stenting. So just some sort of anecdote there. 116 patients with papilledema, as we were talking about, 40% resolved and 38.2% improved. So about 75% of patients improved. The retinal nerve fiber layer, mean improved from 170.2 micrometers to 89.2. Visual fields improved in about 135 patients. So good evidence that markers improve after venous sinus stenting. Here we again see this area of narrowing. This is an example from that publication. It shows the papilledema from fundoscopic examination. This is the OCT looking at the increased in thickness of the retinal nerve fiber layer, about 442 micrometers, as we can see, and that favorably gets affected, as we can see nicely demonstrated here with stent placement, post-stent placement. And visual fields get improved. This is I realized going through that it's interesting that the visual fields are also measured in decibels. That's an interesting thing, just as a note. It's the luminosity that they assess in decibels. So this is just a graphic representation of opening pressures pre and post stenting. 804 patients. This is the different trials that were reviewed, and we can see how consistently all those patient groups have a favorable post-stent opening pressures. This is other symptoms, as we had talked about: headache, pulsatile tinnitus, visual symptoms, diplopia, and transient visual loss. So improvement in this blue color where resolution of symptoms, and here is where we were talking about headache improvement. Resolved to improved becomes very subjective. And Dr. Fargan, one of another heavy practitioners of venous stent, he also says over the years he has been paying more attention to scales of headache and how we can objectively quantify headache, and that there is improvement in those scales. But the jury is still out on how objective those scales are and validation of those scales. Outcomes of papilledema, as we said, most significant, about 80% resolved or improved. Interesting that optic atrophy happens in about 3.6% of patients. It's interesting how the optic atrophy happens. Don't know the pathology. Maybe it's venous congestion, and that deteriorates optic nerve integrity. So up in the air, love to see from neuro-ophthalmologists on the call or Pierre to see his thoughts on that. Here is the retinal nerve fiber layer, again, significantly improved, which is a marker of papilledema and more intricate marker, I would say. And this is the decibel mean deviation of visual fields. Again, standard deviation and kind of like improvement that we see in all the different group of studies that are now the larger one, which is Umeide's study, which is 76 patients. But again, we don't see that significant of a difference here, which is interesting. Okay, so complications of venous stenting, low is, I would say, is the main sort of message here. But bad things can happen. People can get subdural hemorrhages where people can poke through venous tributaries as we are navigating through these narrowings. ICHs happen, I think, with venous thrombosis and congestion, venous stroke. Cerebral edema can happen, again, counterproductive venous congestion and thrombosis. Stent migration can happen. Death is, again, very, very rare. I think it's related more to if you get intraparenchymal hemorrhage and subdural hemorrhages. This is a catalog from that same publication that we were looking at, which is detailing all different types of complications, including groin hematomas and abscesses and sepsis. As we can see, very, very low. Improvement in symptoms, we can see ipsilateral headache is quite high. Stent thrombosis, reasonable number in that 1,626 patients, but very low percentage. Transient hearing loss is another symptom, again, low. Instant stenoses, and as you can see, migration, extravasation, all of these things are related and have been cataloged nicely in this particular publication. Recurrence of symptoms is requiring follow-up and surgical intervention is still a problem, and a reasonable percentage of that. And as we do more venous sinus, as our experience grows in the venous sinus stenting group, I think we will start to see recurrence as well. And would love to see what Pierre's thought is on that. So wrapping up, in summary, I think there is growing body of evidence for endovenous treatment for well-selected patients with idiopathic intracranial hypertension, especially with medical refractory disease, and carefully selected patients through pressure gradient measurements and objective markers that we are trying to sort of get to with non-invasive imaging, MR venogram and MRI. We are looking at the moment trying to get to pressure measurements from the MRI. We'll see how that goes. And that would be nice to have an objective marker that will obviate pressure gradient, intravenous sinusoidal pressure gradient measurement. We can get to the treatment point directly from that. Failure rates are similar to our surgical equivalents. And as we see novel stents like the River dedicated venous sinus stents are coming up in the horizon, we'll see what the trials show. And prospective trials, I think, will be useful in the future in this regard. I'd like to close on that, acknowledge our neurointerventional fellow, Dr. Sifrig's contribution in getting some images together and helping with the presentation. Thank you so much, and would love to see what everybody thinks and questions.
Yes, I have a question on pulsatile tinnitus because I think you, I mean, you gave a name, but without describing it. Many patients have tinnitus, but it's not pulsatile tinnitus. So what I tell my patients is, do you hear a zzz? And then this is regular tinnitus, but the pulsatile tinnitus is something very specific. It's a and when they hear that, this is a vascular tinnitus, and it should be explored for a vascular origin. Would you mind commenting on that?
Absolutely, Pierre. I think I completely agree. I think the pulsatile nature of the sound that the patients perceive is significant. I mean, I think that there's so many different causes, as you were pointing out, for tinnitus, and people are now getting more granular with what type of tinnitus, whether there is a ticking sound or humming sound, or is it in synchrony with the cardiac cycle. And that leads to the point of where I was talking about the possibility of a dural arteriovenous fistula. So with the papilledema presentation, which is why we have mentioned in our publication in the Journal of Neuro-Ophthalmology that the dural arteriovenous fistula typically at the sigmoid transverse junction is a papilledema shunt, because that can present with papilledema. As we were trying to make that distinction of dural arteriovenous fistulas in the cavernous sinus, which can present with red eye shunt or a white eye shunt with diplopia, vision disturbance, as opposed to papilledema presentation with dural arteriovenous fistula. That is why I was suggesting that pulsatile tinnitus should be a red flag, where non-invasive imaging now, I think, arterial spin labeling, MR angiogram has some credibility in picking up subtle dural arteriovenous fistulas. But then again, catheter angiogram is the best way to exclude that. And that is sort of hitting two birds in the same with the same stone type of thing. IIH patients where there is maybe a suspicion, and I still have to think about an indication of IIH that we are doing arteriography and venography for pressure measurement, that we incidentally pick up a dural arteriovenous fistula. I don't think we have had a case like that yet, but we have had papilledema where IIH was being thought about, but then more granular look at the non-invasive imaging suggested dural arteriovenous fistula that we then found to be true on catheter angiogram.
So there is a great question from Renee, who actually, she summarized the problem very well. So she was recently diagnosed with IH. She has moderate to severe papilledema, opening pressure of 36 after 2 weeks on Diamox. She does have RNFL loss. Ophthalmologist is not yet concerned for her vision. She's being managed by Diamox and Topamax. She has lost 15 pounds, which is kind of exceptional. It's so difficult to lose weight that 15 pounds, it's really great. And Renee states, my main concern is obviously preventing permanent vision loss. However, another goal of mine is to eventually get off medication, given the amount of side effect I am experiencing. Metabolic acidosis, word finding difficulties, stuttering, impaired memory, that's a problem with medical treatment. So given the fact I have sinus stenosis, I wonder if stenting is recommended for long-term management of this condition. So at present, there is no stent approved for this condition. So no, we cannot recommend stenting at present being on label. I mean, myself as the representative of a company, Serenity Medical, the River Stent is not approved yet, so we cannot recommend it. But that's exactly why why I founded this company, and to give the physician a stent that is FDA approved and that is made for the sinus. So patients like René can be treated with an appropriate stent used according to FDA specifications. So that was a great question. So I have a question for you, Neeraj. When you stated that some cases it's very difficult, that you have to use the jugular vein approach, which is actually not a big deal to do, but it's still a little bit invasive, and it means that you have to push. So you say that you use the arterial stents at present. So what properties would you like to see in a dedicated venous sinus stent?
Yeah, so it's a great question, Pierre. I think so. From a technical point of view, we face this issue of delivering these arterial carotid stents, which are used off-label. They are stiffer, And to get them around the jugular bulb into the sigmoid sinus, they do not cross that turn well. They push all the construct of the guide catheters back rather than going forward around those bends.
So you
And that
want
is,
a stent
yeah,
that will navigate easily. And
yes.
what else would you like to see?
So it's navigability is one. The other is ease of deployment. So not having too much radial force that will distort the sinus and lead to, uh, in just laying the stent, some luminal discrepancy at the end of the stent, edges of the stent, because it is very hard to categorize the size of the stent and match it to the sinus. The shape of these stents, as you know, this is circular, cylindrical, and the venous sinus is triangular. And that is one of the properties, as I know, the River Stent has a profile which is more triangular with a curve at the edge. So I know that the technology there has been to make it to be more amenable to conform to the shape of the sinus. And I think that is a big thing, because distortion of a sinus by placing a cylindrical stent in itself distorts the
Yes.
absorption, distorts the whole physiology, I think.
So the river stent is still circular. You cannot make a stent that is a triangle. However, it is soft, and we have an open cell design so that it adapts better to the sinus anatomy. But we cannot make a triangular stent
Yeah.
at present. But
I
it will be better than the arterial stents. Yes. Yeah.
yeah.
This
No,
is
yeah.
what so we enrolled 39 patients in the study for the FDA approval of this stent, and every physician stated that the stent was very easy to navigate and very easy to deliver.
No, this is great. And also, I think, correct me if I'm wrong, the property of the stent is their longer length, right?
Yes, it is 7 centimeters long, so you don't
Yeah.
have to put two stents. So
Right. Right.
only one stent will do the job. Yes. Yeah.
Yes. Yeah. So that is a plus also, because stents that are there existing, which are 40 millimeter, maximum 50 to 60 millimeters. But if you need longer, then you're stuck. You're kind of like doing telescope stents, and where in a vein where experience of natural history of stented sinuses is still up in the air, it's better not to have more metal put in if you can help it. So from that point of view, it is good that a longer stent is in the horizon. We'll see what the results of the study show. But
Do we have a few more minutes, Barak, or should we?
Yeah, I mean, I think if there are more questions, let's go on a little bit longer.
So this is Heather, who said, I've been diagnosed since April 2023. My papilledema has resolved. Excellent. I've lost 25% of my weight, which is, again, it's outstanding. However, my ICP is still 28. You know, that's a problem that that I have seen is if you lose, if a patient can lose weight fast at the beginning of a disease, then IH may not go chronic and may go into a remission. But for long-standing IH, losing weight, even 25%, may not be enough, and the symptoms will persist. Hyper continues. I have severe daily headaches, pulsatile tinnitus, hearfulness, pain, visual disturbance. So all the symptoms of IH. And there is also bone thinning confirmed by a sinus CT. Yes, this exists also is due to the stenosis, and then there is a high flow, and this can thin the bone and increase the intensity of a pulsatile tinnitus. I am not being treated for the high ICP, it's not an issue. So high ICP itself is not an issue. So I think we can reassure Heather that in IH is not an issue as long as there is no papilledema and visual field defect. But some patients with IH are feeling bad with an ICP of 25, and some are feeling well with an ICP of 30 or 35. It seems that there is not a very tight correlation between the ICP and the symptoms. The problem of high ICP is for the vision. If it gives a severe papilledema, then you should not keep papilledema for a long time, because papilledema is really the engine of visual loss. And visual loss can be delayed. So during months, sometimes years, patient can have papilledema, and still there is no obvious vision loss, but then the appearance of vision loss can be delayed after papilledema. So I think it's important to treat papilledema before there is actual vision loss. I mean, not if grade 1 papilledema, but grade 2, can be treated with Diamox. But if you have a grade 3 papilledema, it should really be addressed. And within a couple of months, you should not wait for years with a significant papilledema, because it will give you, it will impair the vision. And the vision, once again, vision loss can be delayed. And yes.
I would completely agree with you, Pierre. I think I would substantiate and reiterate that this is why it is very important to be followed by ophthalmology and neuro-ophthalmology on a regular basis. If you lose contact, everybody doesn't understand visual changes as ophthalmologist or a neuro-ophthalmologist would do. And their expertise is very important to flag these things up to experts and people with treatment expertise like Dr. Goban or like myself to bring it to our attention. So I think that's where the team is very, very important. If you're being followed up for vision loss or vision changes by primary care, if it is not improving, if something else is being thought about, I would get to a specialist's evaluation. And that would then galvanize and kind of like crystallize whether we are dealing with IH. Is it like chronic IH? Is it acute IH as being suggested by Pierre? So it's very important to keep a tab on it. If any deterioration is suggested and vision disturbance is being seen, then which is deteriorating, then still there is a role for treatment and potential venous stent.
So we have many more questions, and I don't know which one to choose.
I know. I can see.
There is a question from Lynn. Do you recommend weight loss medication if you are having difficulty losing weight, or bariatric surgery? And the answer is yes. If you have IH and if you are overweight, not a little bit overweight, but if you have significantly overweight, that's, in my opinion, that's really an indication for weight loss medication. Yes. Bariatric surgery is also, it's a very effective procedure, but it has also many short-term complications and long-term complications. So I think that weight loss medications are the first one to try, and reserve bariatric surgery for what we call a morbid obesity, where the BMI is higher than 40, and where really you have tried everything else. But yes, starting with a regular diet and physical activity, then going on weight loss medication, and keep the bariatric surgery. That's for really when there is no other solution. Yes.
I would agree again, Pierre, and I would add that there was just a word of caution from use of weight loss medication, right? There is a lot of press about anti-diabetic medications and people using them for weight loss. There is some suggestion from FDA that one should be cautious. There is some evidence that excessive use of that weight loss medication is also not that great, as with everything in medicine. So
Yeah, and the
just something.
problem is, same thing, the problem is with chronic usage. This medication
right.
given chronically can impair your liver, etc. But certainly those new weight loss medication, the GLP-1 agonists are fantastic. Yeah. So there is another question about tinnitus. So I'm going to say it again to do the sound again. If you hear a continuous sound, okay, like a zzz, or like a ringing or something that is continuous, that is not pulsatile tinnitus. Pulsatile tinnitus, that's the whooshing sound, that's really the tinnitus of that pinpoint to a vascular etiology, to a vascular origin.
Completely agree. And I would also reiterate that the whooshing sound that Pierre was just mentioning, if it is in synchrony with the heartbeats, that is where you can be confirmed that, okay, that is pulsatile. That's one of the markers. And as is being suggested, vascular cause is the foremost to exclude.
Okay, very good. Thank you, Barak. Thank you, the team at BKW to allow us to do those webinars.
No, thank you for allowing me to participate. It was great. I think the great interaction. So thank you so much for that opportunity.
Oh, yes. Can we have, just before we wrap, Nicole would like to share something. She's in the audience. And Nicole, can you come on screen? We'll feature you.
Oh, yes.
Hi, Dr. Chaudhary.
Hi, Nicole. How are you?
Good. How are you?
Hanging in there.
So Dr. Chaudhary is my neuro interventional surgeon who just performed stent placement surgery in May of this year. So I'm still recovering, but I'm doing well. And I just wanted to share, that it is a little bit of a healing period still. I have a stent in my left transverse sigmoid sinus, and it has made such a difference in my quality of life so far. So my symptoms are slowly fading away. I just have the stent pain a little bit, but it's still pretty manageable. I do have a lot more of my story that I've shared on the hub. I think that was, when was that? Back in April of this year. So, but yeah, I came to Dr. Chaudhary about not even a year ago. I'd seen lots of specialists before I reached Dr. Chaudhary. I had seen ophthalmologists, neuro-ophthalmologists, 4 neurologists, and this is kind of a full circle moment because IIH Hub is where I learned most of what I know now about interventional radiology, and was able to ask for a referral. And that's how I came to Dr. Chaudhary. And we had a diagnostic angiogram venogram in December of last year and found that I was a candidate for a stent. And so that is kind of the year-long process almost of how I came to get some relief from my symptoms.
So are you feeling better?
I am. Yes, the biggest difference is the pressure in my head is virtually gone, meaning that I can do most of what I was doing before, not full activities, not like strenuous exercise or anything, but gardening, bending down to tie my shoe without my head having a ton of pressure. The pulsatile tinnitus is starting to fade away as well. I think there's still a little inflammation there. I also have the type of IIH without papilledema. So there's not a lot of difference there, although I'm going to be seeing Dr. Kornblath for a follow-up. Will let me know if anything has changed in that area. But yeah, I just wanted to say thank you, and that there is some hope when you get the right specialists and care.
No, thanks for sharing that, Nicole. I think it goes to show that this problem is not straightforward. The understanding of this problem is, we're all sort of gradually starting to learn more and more. People used to diagnose this condition and then come to a stop of like, okay, conservative management, and what else? Okay, if the vision is deteriorating, like going down the cliff type of thing, okay, urgent surgery, shunt CSF diversion surgery, or if there is gradual progression, then as Pierre was mentioning, bariatric surgery, weight loss. But not every patient is that does fit that profile. There are a lot of patients who are not of a certain BMI and still have papilledema, still have features of intracranial hypertension. So that it goes to show that how not well understood the physiology of CSF is. And that is what we are all trying to understand better, with better imaging, better ways to quantify. One of the things I think is that CSF volume and how it changes when person is lying down or sitting or standing, as you were saying, bending down. How does that change? I think those variations, if we are able to measure objectively, it'll be something. An objective, non-invasive measurement of pressure gradients is something that I think we all should look to solve. So thank you for sharing your story, Nicole. I'm glad you're doing better.
Thank you.
Thank you, Nicole. I'm really glad that you spoke. Nicole actually led one of these webinars recently. We had a community chat, and she was wonderful. And in fact, I want to close by thanking Dr. Chaudhary so much, and Dr. Goban as well for moderating. In closing, I just would like to invite you all to just know that we are, sorry, I'm just trying to share my screen here. We do these seminars pretty frequently, and so we hope to see you at future ones. In between, you can always come to the IIH Hub. This is what Nicole was mentioning. There's a side for patients and a side for physicians, and of course, you can go in either side, and we recommend that you go get the different perspectives. We recently added something in the patient side, which was very much inspired by, and we got help with it from Nicole, which is the patient journey. And we have a hypothetical patient, and her journey starts in various different ways, but you can also begin your own journey. And this is where you can learn about different doctors in different areas. And people are starting to also leave their own stories here, which is very nice. Someone just left a long story about their journey just today, actually. So come here. Also, we have a YouTube page. There's a lot where you'll find all the old past webinars, as well as this one, and also short excerpts. So I invite you to check all that stuff out, and we'll see you next time. Thank you so much.